Well, thank you, Mary. Now I'm going to introduce Dr. Matt Thompson. Matt Thompson grew up in Spokane and attended Gonzaga University for undergrad and the University of Washington for medical school. He completed his pediatrics training at Children's Mercy Hospital in Kansas City. Dr. Thompson and his wife have 6 children and are happy to be living back home in Spokane. Dr. Thompson has been practicing general pediatrics since 2004, most of that time spent in a 2-provider practice that he started with his good friend and colleague, John Lee. In addition to serving on the Myhre Syndrome Professional Advisory Board, Dr. Thompson has served as a trustee on the board of the Washington chapter of the American Academy of Pediatrics. He also serves as a board member on the U District Foundation to promote the health and well-being of children through fitness and nutrition programs, camps, and mentorship programs. In addition, he is the medical director of Hoya Child and Family Development, a birth to 3 neurodevelopmental center that provides early intervention services to infants and children. His work at Hoya has given him the opportunity to work with many children with rare neurodevelopmental and medical disorders. Being a member of the Myhre Professional Advisory Board offers Dr. Thompson an opportunity to interact and collaborate with pediatrics colleagues with rich and varied backgrounds. So welcome to the conference, Dr. Thompson. He's going to give the PCP's perspective, how to create your home team and learn from each other.
Greetings, I'm Dr. Matt Thompson, a general pediatrician at the Kids Clinic in Spokane, Washington. I want to thank you for sticking it out to the end of the first day of the first Myhre Syndrome Foundation Symposium, which is very exciting and hopefully will be the first of many to come. Maybe it'd be nice if they could be in person, perhaps in your hometown next. And I would vote for Miami or Hawaii or Italy, Australia, or Boston in the summertime would be nice. So hopefully it could be one of those places in the future. I'm very honored to be a part of the Myhre Provider Advisory Board. It has allowed me to come into contact and work with colleagues all over the world. And it has been an extraordinary experience for me. So I thank all of them for letting me be part of this. I know you all know lots about Myhre syndrome, even more at the end of the day, but I thought I'd go over a little bit of the history if someone hasn't mentioned that yet. And so here is the Rainier School in Buckley, Washington. You can see it with Mount Rainier looming above. And this is where in the 1980s, Dr. Selma Myhre first described 2 young men with similar features that would later become known as Myhre syndrome, and fairly recently, become known to be due to a SMAD4 hyperfunction mutation. Hopefully, the Rainier School continues to operate and is a habilitation residence. So it's a place where individuals get to work and derive the benefits of being in a community that supports individuals that might have special needs and things along those lines. I hope it can stick around because Mount Rainier looming above there is actually a volcano. So hopefully it won't blow its top anytime soon and wipe out Dr. Myhre's legacy. So my Myhre journey began with this handsome young man, Will, 9-year-old in my practice, who I've cared for since birth, and I'm actually friends with his parents. Our families spend time together, and that precedes Will's diagnosis. His dad, Rob, and I are in a book club together, which is really a bourbon club, but we do talk about books while we sip. But it's been a true privilege to get to work with Will and Brooke and Rob and Dr. Lynn and a cadre of local specialists who have helped coordinate and help with his care since his diagnosis with Myhre syndrome. There's this nice family out at the lake. So I really am grateful to them because I have, I think, become a better pediatrician that are able to care for children with complex medical needs through working with them, Dr. Lin and all the others. So I think it's good to ask the question, how rare is Myhre syndrome? And I'm sure many of you know it's exceptionally rare, perhaps 1 in a million or even more rare. It may be less so as time goes on because more individuals will likely be identified with whole exome sequencing, as was Will, but it is still going to be quite rare. And why that's important, I think, is a little bit of context. My practice, we take on about 200 newborns a year. So I would likely, not just me, but my partners would likely have to work another 5,000 years to statistically have another patient with Myhre syndrome. Now, your specialists like Dr. Lin and other medical geneticists will likely have more experience, obviously, because they're a referral center, and so they catch individuals from all over the world, really. But in your primary care provider, in their home, in your medical home, it's very likely that they will not even maybe have heard of Myhre syndrome. That's okay, because you are going to teach them about it. You're going to direct them to the resources on the Myhre Syndrome Foundation website. That is a wealth of information about Myhre syndrome, both background and workup and surveillance and all those tips. So it's going to be okay. They don't have to be an expert on Myhre syndrome, if you ask me. They will become more expert over time, but hopefully they're an expert in the needs of your child, and also will just be skilled at coordinating care for a child or individual with complex medical disease. And that is why it's important to appreciate the rarity of Myhre syndrome, in my opinion. Okay, so as you all well know, there's many different specialists involved on the team. So this is the kind of the special teams of Myhre syndrome. And by the way, I want to say, I apologize. I realize I'm referring to children and their parents, and I realize some of you may be adults with Myhre syndrome. Some of you may have adult children with Myhre syndrome or adolescent children. But as a pediatrician, my experiences with working with families with Myhre syndrome, hopefully some of the pearls, if you want to call them that I might impart today, hopefully they'll still be applicable to any age in terms of operating in a primary medical home. Okay, continuing on. So Brooke, Will's mom, likes to say that as his pediatrician, I'm the quarterback of the team. And I respectfully, sorry, Brooke, but would have to disagree. I think I'm more like the team manager, who organizes the water bottles and makes sure that the water's plenty and fresh, and keeps track of the towels and tapes some ankles, maybe takes some stats, and generally serves to support the team in morale and in other ways. I think the medical geneticists really are the quarterback. I guess I might be just passing the buck a little bit, but they really do have the experience and the training and the skills. And I've never met a medical geneticist that wasn't highly organized and very smart. And so I think they're a great quarterback to help, set out the plans, and then the families and their primary care providers help to carry those plans out. All right. So let's move ahead here. All right, so I think it's maybe worthwhile just to mention a little bit what I do as a pediatrician, which in some ways, well, it's quite different than what an internist does. But so again, I'll speak from my experience, which I also concede is an American experience with our particular healthcare system. So I apologize, I'm not as familiar with the way things operate in Belgium or Norway or other communities, but hopefully, again, some of these tips can be useful just the same. But I think that it's good to first consider, what does a pediatrician or a primary care provider do? A big part of it is well care. I will see a newborn or a child 6 to 7 times in their first year of life, 6 to 7 times in the next 2 years of life, and at least once a year thereafter from birth until young adulthood. Even some kids I'll follow through college just because it's hard to find a new provider often while you're in college and an adolescent. But as a pediatrician, I work with parents from day one, being there to provide support for questions they may have about their child's health, about development, growth, nutrition, behavior, constipation, just all the things, how to progress feeds, parenting in general. And so that's a big part of what I do as a pediatrician. But I'm also all the while surveilling and kind of keeping an eye on milestones and seeing if this child is meeting them. And if not, perhaps pursuing some diagnostic clarity, or at least just informing the parents, referring for services, things along those lines. So that well care piece is a crucial part of my job as a pediatrician. I also help with ill care, which there hasn't been nearly as much of this year with COVID restrictions. It seems that hand washing and masks and things like that really helps reduce the sharing of bugs. But I am available if there's concerns about ear infections or even the common cold, behavioral issues, which actually is one of the other important roles I think I serve. We provide vaccinations, and perhaps most relevant to today's discussion, we help coordinate complex medical care. So the most modern way to describe an ideal practice scenario is it a patient-centered medical home? That's the big catchphrase here in the United States lately. And I'd like to talk a little bit about what I see as the features of what makes for a good patient-centered medical home. In other words, a good primary care office for you and your child or you. And I'd like to start with the definition put forth by the American College of Physicians, which states, and I'll read it because I want to get it right: the patient-centered medical home is a care delivery model whereby patient treatment is coordinated through their primary care physician to ensure they receive the necessary care and where they need it in a manner they can understand. The objective is to have a centralized setting that facilitates partnerships between individual patients and their personal physicians, and when appropriate, the patient's family. Care is facilitated by registries, information technology, health information exchange, and other means to assure that patients get the indicated care when and where they need and want it in a culturally and linguistically appropriate manner. It's quite a mouthful, but I think it's does a nice job of kind of describing what we're going for with the patient-centered medical home. And so what are some of the features of a patient-centered medical home, in my opinion? One is, how easy is it to access your team? And that's not just the primary care provider, but all members of the team, because there may be medical assistants who send referrals, there may be billing people that can be useful. So in general, do you feel like when you call, you get a human fairly quickly and not just a series of machines and voicemails and things like that? I know in modern times that's part of life, but hopefully, ideally, you'd find a medical home where you feel like, yes, when I have a question and need answers, I'll find out in the next day or two, and not have to make an appointment for 3 weeks later to ask your question. So I think access to the team is a crucial part of the patient-centered medical home. Then, does the PCP communicate not only with you, but with other specialists? I think this is an important role that we serve as primary care providers. Is we're a conduit between families and parents and their children and the specialists who may take months to get in to see. Once established, they may be more readily available, but in general, it's nice to be able to have that conduit. And unfortunately, the reality is it's usually a lot easier for a primary care provider to contact and speak with another clinician than it is for a parent. Because there's one thing that is true for pretty much all pediatricians, maybe all doctors, certainly these specialists, we're all often very busy, and often have more than we can bite off and are trying to cram 10 pounds of potatoes in a 5-pound sack, as they say. So it's despite that, it's particularly, I think, important if you're able to take advantage of their ability to communicate. And then, yeah, so will they do that for you, hopefully? So how well the team communicates within the office is very important. Intra-team communication has been found clearly to improve patient satisfaction in all settings. And that makes sense. When you call and speak with one person, it's nice if they follow through and convey to the others or follow through with your questions, et cetera. So hopefully there's not too much disconnect between the front end, who you call, and the middle staff and the back end, the clinicians. And then hopefully they also communicate well between offices. They're diligent about if referrals need to be sent, they do that. Just getting records from outside, hopefully they're diligent about those communications as well, which increasingly, depending on the community you live in, there's more and more practices that share the same basically scheduling and electronic medical records, I think, which really can facilitate that communication quite well. But there's a lot of different versions and a lot of different formats or platforms of electronic medical records, and they don't always communicate together. But you may, that might be something that also is worth looking into when considering a patient-centered medical home. Do they share a similar system to most of the specialists they might refer to? It could be helpful. And then more specific to the communication with the PCP, do you feel like you get to communicate directly with them, whether it's through a patient portal that's encrypted or encrypted email, or is it more, you leave a message with the medical assistant, the provider answers. And I know in my practice, we do get a lot of questions called in. Basically, the medical assistant transcribes their question and perhaps might call back for some follow-up questions if there's some obvious things that would be helpful to know. And then I'm able to read their question and I respond to it in type. And then often I ask the MA just to read it verbatim instead of trying to, interpret or soften or whatever, edit what I've said, just to so no nuance is lost. And then that becomes part of the medical record too. So I kind of probably drive my staff crazy because I can be a little verbose, but I think it's important to be clear and have the ability to look back months later, years later, and see what the thoughts were at that time and what the recommendations were. So big question, does their EMR improve efficiency and function or deter from it? When practices are starting with a new system, it seems pretty common that they'll complain, oh, sorry, I couldn't do that. We have a new EMR. Well, hopefully soon or already everyone's well established with their EMR. They're used to them. And hopefully, yes, it facilitates things. Hopefully when you're in a room with a provider, you're not talking to the back of their head, which is looking at a computer screen the whole time. That would be I would say an EMR that detracts from the experience. But this is just a wish list of what would be ideal. So I know that's not always possible, but I think this is very important. Does the office believe that, I guess you could say the office culture believe that the medical record is property of the patient or guardian, and do they facilitate the patient and guardian possessing those records for transparency's sake, for organization, for clarity? I just can't overstate how I think that is so important to realize. And quite often I know a lot of parents run into roadblocks, but I very much encourage my families to be part of our portal system so they can read my notes, because I'll often say to them, I know I've talked in circles here, so please check back with my note where I'll actually number things and be a lot more clear. So I think it's really helpful if you have a patient-centered medical home that allows you access to those records, because they are yours. So here's some general principles. So let's say you found your medical home you want to be part of, and now here's some tips of, I think, how to smooth out communications with that medical home. I can't emphasize enough how important I think it is to communicate with written word, not just through a message left with an assistant. Again, as I mentioned earlier, this way all your thoughts and concerns are there to see and can be responded to directly. And there's not, the phone game where things change a little bit from each individual that's told the story. Yeah, I think narrative is very helpful. And then I would let the provider know, if you agree with this, that it's helpful for you to be able to write down your questions and concerns and ask them how they would like those questions and concerns communicated to them. Would they prefer you to send an email ahead of a visit? Will they prefer you to save that list of questions for an office face-to-face, perhaps a televisit, which are more common these days, or just ask them? And I think it's courteous to say, look, I hope you can help me with this desire of mine to be able to be clear and communicate clearly by writing down my questions and such. And then whether, yes, it's through the email, snail mail, secure patient portal. That's right. Offer options for communicating back. That's right. And let them know you'd be happy to hear back from them via email or a portal message or phone call or text or both. So I think just trying to basically acknowledge that you want to be part of good communication. And then I always think it's worthwhile, especially when you have a complex medical needs, to consider sending in advance kind of a wish list for what you'd like to cover during a particular visit. I think that can make it more efficient. It lets the PCP know the nature of your concerns and gives them time to prepare for the visit. In some cases, they may need to, or have answers ready at the time of the visit, and just hopefully have a richer visit. I have a little mock-up idea or example. I think, first of all, it's important to say that it never hurts to preface a list of questions like this with, if it would be best for me to make an in-person appointment or a virtual visit to address my questions, I'd be happy to do so. But here's an example note. Dear Dr. Awesome, I thought it might be helpful for you to know the issues I was hoping to cover during our next visit or series of visits. Topics I want to address include: 1, scheduling a sedated hearing exam at the same time as an ear cleaning and dental cleaning and an eye exam under sedation; 2, getting help with the terminology used in the individualized education plan for the new school year for my son or daughter; 3, address concerns about sleep apnea, fitness goals, discuss the COVID vaccine. Thank you for working with us on these issues, and let me know if you would like any additional information or if I may be of help getting the ball rolling with any or all of the above issues prior to our next office visit. You can communicate with me by phone or text, this number, by the portal, by my personal email, bestpatientever@gmail, or in any other manner that suits you. Sincerely, Miss Best Patient Ever. So hopefully that, just an example of, man, wouldn't that be a great letter, I think, as a primary to receive, and just really have an idea of what you're hoping to get, the parents hoping to get, and give you an idea of like, okay, we're going to need 3 visits for that, or we're going to need an extra long visit, or what have you. What's really hard, and I must admit frustrating for a primary care provider, is when an appointment is made for a simple rash, but really they wanted to talk about depression and anxiety, suicidality. That doesn't happen, fortunately, very often, but it's just great, I think, to be clear and straightforward and transparent with what your goals are. And I hope that most will accommodate those. So, okay, so I think an important part of having a child with complex medical disease and feeling hopefully some sense of control and some sense of being on top of things is getting organized, is being organized. And we have certain vernacular in medicine. We talk about a problem list. Those can be very useful. They start, ingraining that in us in training about, what's on the problem list, what's a differential diagnosis, things like this. And problem list serves to give you a template of relevant issues to keep track of, all the while caring for an individual. So I think it's a great idea to start simply by identifying what appropriate systems and what a problem list is for your child, given them having Myhre syndrome. So I've made a little example here, a little body map, and obviously there's a lot of words here. We don't have to go through every one, but you might, start at the top and say, in terms of the central nervous system, we will likely have a neurologist, we may have a neurologist, ophthalmologist, audiologist, psychologist, etc. In terms of dental hygiene in the mouth, we have dentists, orthodontists, speech therapy and swallowing therapy, possibly airway, otolaryngology, anesthesia, et cetera, et cetera. And so you kind of have your map, and obviously you may not have, I hope you don't all have to have every one of these specialists. Wow, that would be a lot, but at least you can keep track of who's on the job of what system. And then identify those providers specifically by systems and by who is involved in those, in caring for those, and give yourself the benefit of making it easier to communicate with them by having their phone number or email address. I would suggest the last visit had, the next visit, any recommendations for future pertinent past imaging, past labs, or future plans. Here's an example of that. So for CNS providers, you may have a little list. And by the way, some of you may be Excel spreadsheet people and keep track of these things that way. Some might be, write it down in a journal. Some might be using either real calendars, paper, old-fashioned calendars, or perhaps a digital calendar. My mom stuffs, Post-it notes in Ziploc bags, and I've never met a more organized person. She can pull a Ziploc bag out of a drawer in the kitchen and tell you what their, policy amounts are for a life insurance policy they got in 1958. This happened last week. That's why I bring that up. So anyhow, important part is getting organized, staying organized. I suggest it. And if you were to see, for example, my workshop at home is a mess. I am not always as organized, but you can be in a hyper-focused way. I think you can kind of carve out areas where, okay, when it comes to this, here's where I really am on top of things. So anyhow, I'll continue on. So another example for ophthalmology, Dr. Peepers, phone number such and such, last visit 9920, next visit 3921, next visit will include sedation and dilation, NPO after midnight, just to give yourself notes about what to expect. Audiology, Dr. Sound, etc. School psychologist, Dr. Ponder, last visit, need to schedule neuroeducational testing for September, IAP meeting in 2021. Then you'll have your airway providers, Dr. Inhale, the ENT, last saw your son or daughter on 6/6/20, next sees them 6 months later. You're supposed to set up an ear exam and cleaning with enough time to reschedule with a dental, audiology, sedation if needed, if the cleaning doesn't go well. Anesthesia, hopefully Dr. Awesome, your primary care provider, will contact Dr. Numb about ideally using a laryngeal mask airway unless intubation is absolutely necessary with sedation for dental, hearing, eye exam, ear cleaning, etc. It's just kind of an example of how I would try to keep a provider-specific problem list. Okay. Now, when we look at problem lists then by system to kind of dial down and get more specific about your individual child and what their most relevant needs are, I think a map is good. Here we see, again, same kind of categories, CNS, mouth, airway, respiratory, but in this case, we're looking at perhaps there's intellectual impairment or learning difficulties, ADHD, autism, hearing impairment, important obviously to follow, vision impairment, communication difficulties, et cetera, et cetera. So whatever might be relevant or an active problem, but also areas you want to kind of keep an eye on, I think those are good to have on your systems map. And then you can go and, get to the heart of things. So, sometimes by the most crucial or life-threatening that can be. So, the airway, and you can keep track of when the last scope by Dr. Inhale was and what it revealed regarding stricture of the airway, cardiomyopathy, last echo by Dr. Hart was stable without significant change, abdominal pain, last x-ray by Dr. Stool revealed significant constipation, improved with increased dietary fiber, occasional Myhre. So again, notes on notes and interactions with specialists. Sleep studies, sleep difficulties, Dr. Snooze, etc. You get the idea. So, and then, oh boy, I'm going to back up because okay, well, I'll just move on. This is an example of a a problem list. This is actually my electronic medical record and what it looks like. And I know it's busy and I know there's a lot of stuff. This is a patient whose mom gave me permission to use her as an example. Her child doesn't have Myhre syndrome, but has DeGeorge syndrome, another condition with a great many systems involved. But they were kind enough. I did black out the names of providers and tried to black out most of the names of family members I could, but anyhow, do have permission. So, there's a lot here, but on the left side, I've got all the information about past surgeries, about their family history, social history, etc. On the right side, you'll see this general problem list, but that corresponds, I can put that into my assessment and keep track of that, and I can make notes along the way in my assessment. Of course, I have all these CPT and ICD codes for electronic medical records requirements and billing and things like that. You don't have to have those, although you could, and it will help you help your provider be even more on top of it and organized. But we keep track of these general problem lists here, and then maybe address in treatment specific to each problem, the active problems and what we're going to do. And again, I would encourage, because look at all this mess. I mean, can you imagine being read this or told this and going home and remembering any of this? So how can a parent not, how can they keep track without hopefully having access to the information? So anyhow, that's why I showed an example here, and I realize as I look at it, it's kind of giving me a little bit of anxiety. So I'm sorry if it's too, busy, but that was my hope, was to just show you an example of a real life problem list that I've used. So because I wasn't sure how things were going to work with a virtual visit and all, a virtual or a remote conference and things, in case there weren't any other questions, I was going to just ask a few of my own, or at least answer a few of my own. So let's do a little role playing here and pretend like you asked me these questions. So how do you find a good patient-centered medical home for me or my child with Myhre syndrome? Should I set up a meet and greet with the provider? Well, I think a great place to start is with the quarterback, the medical geneticist. Specialists who are referred patients are almost always sent some of the notes from the providers. So they end up getting to read everybody in the region, all their notes, and they get a sense of, I would imagine if you were asked them, who seems to be a little more on top of things with complex medical needs, or who might, be an option if you were to ask them who they would recommend, things along those lines. So ask the quarterback. I know in one of my capacities, I do a lot of chart reviews, and you really do, you can tell the ones that don't seem to be keeping track of much anything versus those that are really on it. And so I think that's a great resource there. You could consider other sources like a NICU case manager. Why not just cold call a NICU and ask to speak to the case manager? They'll probably be, a little surprised. This probably wouldn't have happened before, but you can ask them who they recommend working with based on their experience with kids with many of the complex medical needs. Are there particular offices that seem to be inclined to take on kids with special needs? Are there particular providers they recommend? Things along those lines. Join a Facebook group or find another support group. Maybe, I imagine you'll be with parents and patients with Myhre syndrome, but also there's DeGeorge syndrome, Down syndrome, Turner syndrome, a number, even extreme prematurity, a number of different conditions that often are associated with complex medical needs. You can ask them, who do they recommend? Do they have a provider they particularly like, who seems well organized, and the office has good access and is a pleasure to work with? I think that's an option there too. And I also want to say there are certain clinicians who are both internists and pediatricians. They've done like extra training, and they can often be ideal for kids with complex medical needs who then become adults with complex medical needs, but also because healthy kids tend to have fewer complex medical needs than average adults. And so they often have quite a bit of experience working with individuals that may be on a number of medicines or just have a number of different medical needs. And then when narrowing in on a patient-centered medical home, I'd suggest calling up the practice manager or clinical coordinator. Again, it's going to be a cold call like the NICU where they're like, what? I never had anyone ask me this, but why not? I would call and ask if they could help you find a good fit for your child who, let's say, who has Myhre syndrome, a rare genetic disorder, and a whole slew of excellent specialists that coordinate the care, but you're looking for a good primary care provider who maybe is someone who likes to care for kids with complex medical needs, someone who's maybe has more experience doing that. It'd be nice for somebody who's really organized, but ultimately, you know, setting up a meet and greet with an actual provider is a hard way to do it because who you see for that 5 minutes, 10 minutes at the end of the day, you know, isn't necessarily who they are or what you'll experience. And so really it comes down to just, you gotta jump on board and see how it goes and try somebody. But I would look to practice managers because they're usually quite aware of who's overbooked or who tends to have a long wait. And that's an important thing I think to keep in mind. Some parents would be happy to wait all day as long as when it's their turn, they get all their questions answered. And some really want to be on time, and that's more important to them than the actual care they get, it seems like sometimes. So anyhow, getting the inside scoop on who might be a good option at a given practice, I think is good. Okay, next question. Might I improve the likelihood of me and my family getting superb care from a patient-centered medical home by bribing office staff or the PCP directly? And the short answer is, of course you would. Now, but there is a lot of truth to the saying that you can catch more flies with honey than vinegar, unless it's possibly an aged balsamic from Moderna that maybe is served with some strawberries and Prosecco. But joking aside, you know, who doesn't like getting some cookies or a jug of coffee or a fruit platter or a thoughtful card that just sends a message that you see them as people worthy of your attention and time? Who doesn't want to be spoken to nicely, respectfully, in a non-condescending way? I know you may feel when interacting with front desk staff sometimes like they need to hear this, and they need to remember people don't like being spoken to in a condescending, unrespectful way. But looking at what changes and the interactions you can have, what you have control over, I would keep in mind human nature, and that, you know, who doesn't want to be acknowledged as a valued member of a team, as a valued member of humanity, especially when they're made to feel often unvalued by others. It can be a hard job at front line. You often have a lot, especially in pediatrics, a lot of anxious, often demanding, you know, parents that want, you know, in modern times, they want answers now, they want everything now, they you know, don't want to be inconvenienced, etc. So you really can rise to the top popularity with an entire office just by spontaneously, sending a card that says, hey, thanks for being on this journey with us. I think, and I will say, Brooke is masterful at this. She's very loved at my office. She's got some amazing spice nuts that she gives us every year. And so I don't know, depending on your locality, these all may be illegal things, you know, giving cookies and things. Hopefully not. I think there's limits to what can be given, but the point is, you really can, I think, work in your own best interest by attending to the reality that we are working together and hopefully as a team, and that it can be a real stressful workplace. And ironically, it seems like it's the parents that have children with the most needs that are the nicest. I mean, that's a bit of a generalization, but often, isn't it ironic that it's often the healthiest kids that have the parents that are the hardest to deal with? But anyhow, maybe you're one of those hard to deal with parents and you could make some improvements that way. And who doesn't treat someone just a little bit better when they have shown them some courtesy and some appreciation, right? So I think it's a worthwhile effort. So in summary, find a primary care provider who follows the model of a patient-centered medical home. Establish a clear channel of communication with PCP and team, ideally using writing to provide clarity and focus. Try to provide questions and concerns in advance. Organize your child's medical team by systems involved, by specialists that attend to those systems, and keep track of past and future visits, along with pertinent details about those visits. Organize your child's most relevant medical needs by making a problem list, which can contain details of their past and future workup and management. And get yourself on the favorites list of a practice, which starts with the front desk. That is what I have for you, what I have to say. And I thank you very much again for being part of this. I put my email down here. If you have any specific questions or if I can help in any way, I'll do my best. But thank you very much.
Thank you, Dr. Thompson. That was fantastic. We have just a few questions for you if you're there.
Sure. Can you hear me?
I can. Hi.
Hi.
Nice to see you. That was really fun. Dr. Awesome.
Yeah.
So the first question is, as a PCP or in the UK, a GP, should the doctor be ordering routine blood work run for basic areas that might arise with Myhre? Often things can be going on that we don't see or know about. So should we be leaning on our PCP or GP to get the basics done ASAP, like a panel of blood work done, and not wait for symptoms?
Well, it's a good question. And it brings me an old saying that one of my mentors used to say, and it is, you don't want to pick your nose in public unless you're ready to deal with the booger. And so, sorry, it's a little crude, I know. But so generally, the idea of a standard panel to kind of keep on top of things is, I totally appreciate that. But sometimes we find when we basically just do tests without specific goals in mind, we can end up actually with some more problems than not. That being said, it would be very, I think, appropriate, particularly if you had a child, for example, who maybe as part of their Myhre syndrome, if they had communication difficulties or intellectual impairment that might contribute to difficulties with nutrition and the adequacy of their nutrition, because their growth is certainly something that will be followed closely and may have their own trajectory. I think it's very appropriate to keep on top of things like a CBC, where you're making sure they're not anemic. Maybe they have adequate iron stores by looking at a ferritin. If they're small, then it would be commonplace to consider some labs that would identify, is it because they're malnourished, and you might get a prealbumin, things along those lines. But I would in general say this is the kind of thing you do want to dialogue with your provider about. Give them a chance to learn about Myhre syndrome and your child's special needs. Following cholesterol is very important over time. If there's any family history of dyslipidemias or things that can contribute to an individual who may have a predisposed risk to heart disease because of Myhre, somebody having a asthma and allergies, and if you can identify those. So I guess my answer is it's a good thought, but it depends on case by case. It's not quite as straightforward as just trying to sort out if somebody has strep throat or not. But again, I think it's great to bring up to your primary.
Okay, thank you. The next question, thank you for your wish list note. Great coaching. How do you recommend dealing with the IEP designations? We have OHI, which I think is other health impairment, on the eligibility criteria. However, as a parent, we would like our students the best access to education and services, not exclusively special education classes. Hearing loss, deafness is also a major concern.
Right, and that's where there's such variability, even within my community, from one school district to the other, with how well they accommodate the needs of children. By mandate in the United States, all children are supposed to be entitled to reasonable accommodation for their learning needs. Doesn't always work that way, unfortunately. I think that my greatest hope would be that you communicate directly with those at your child's school who are in charge of this. There's usually someone designated as and though special education is part of it, there are many other aspects, even somebody needing, special accommodations because stairs are difficult and they need to have an elevator or a ramp put in and things like that. I think the biggest thing is you just get the ball rolling and you lean on your primary developmental specialists if they're involved, because they can help, with the specifics of your child's needs in that particular community. It's hard to mandate everybody do things the same way, certainly, and it's hard to know what a child's needs will be without knowing that child individually. But that's their job, and hopefully you'll be fortunate enough to be in a community that does it well. And if not, I know that's not easy because it's hard to just up and move.
Yeah. Thank you for that. So the only other questions are, how do you break up with your primary care provider? And do you have
how do you break up with them? You say, it's me, it's not you, it's me. No, it's a good question. And I think it is good to explain to them. As you may have gathered, I am a fan of writing it down, sending a letter. I think a letter that might detail, thank you for providing care for these years or whatever it may be. Since our diagnosis of Myhre syndrome, we realized there's a special set of that our needs perhaps lead us to want to shift to a different primary care center. And you can list specifics, because they have a better EMR than you do, or because they're, and I think we should give them a straight answer in terms of, because I find it difficult to communicate directly with PCP, things along those lines. I'd give details. You can always be grateful for their effort and attempt, and you can always be courteous in your farewell. But in general, I would give them specifics. And sometimes, that provider, and hopefully you'd be okay with that, would want to call you to find out more information about it, because that might be how they become a better provider, their office become a better patient-centered medical home. So I would recommend you just break it up, just state exactly why you feel like their needs are more or will be better served elsewhere. And here are the reasons why, and feel free to reach out if you wish, and I can give you more specifics. Something along those lines.
Great answer. Okay. And then people are asking, could you be all of our kids' pediatrician?
Oh, sure. Yeah, that won't be a problem at all. Yeah.
Okay. All right.
As long as you can do televisits. Yeah.
Okay. All right. Well, we really appreciate your time here today during the conference, and also serving on the professional advisory board. Thank you so much.
Thank you very much. It's a privilege.
All right. Bye-bye.
Bye-bye.